Gosh, does that sound quite loud, that speaker? Anyway, I'll keep talking, it makes me sound very important. Very warm welcome indeed to today's annual Reform Health Conference, moving towards a transformed NHS. My name is Andrew Woodman, I'm Director of Reform, which is an independent, non-party think tank whose mission is to find a better way to deliver public services and economic prosperity in the UK. Well, here we are, a full room in the heart of Westminster to debate the future of health policy. This morning, I'm exceptionally grateful for such a senior group to give up their time to be with us today. There are people in this room who have been supporting Reform's work on a better value NHS for many years, but dare I say that this year's conference feels particularly important. Across the road there in the Treasury, and just next to it, 10 Downing Street, the Prime Minister has called for a new health policy for this country, rebooted in the name of innovation and productivity. She has said that the government seeks a long-term funding platform, perhaps for 10 years, and of course is to provide extra resources, but crucially it is to give NHS leaders confidence to invest in the changes that will lead to better outcomes for citizens. And Jeremy Hunt has said that he wants the outcome of this important process to be a health service that delivers a higher rate of productivity than the current level of 1.6% a year. So I don't think it is an over-exaggeration to say that this is another turning point in the direction of health policy. I do think it's a colossal opportunity to help policymakers understand how the health service is currently working, the kind of changes that are needed to really put it on a more sustainable and higher performing footing. And it's a big job to do for this think tank, no pressure for everyone here, but I think it's our job today, to start, coming up with the ideas, feeding in the ideas that means we can really make a success of this important moment in health policy, as I say. So I'm so grateful for your attendance and for your ideas today. I think we've got the right agenda set out in this very pink conference brochure, which I hope everyone has. We will talk about giving power, and not just power, real resources to patients. And I think the concept of the empowered patient has been under-discussed in recent years. I'm thrilled that we're beginning with that today. We will move on to technology, both its general impact in the health service, and then more specifically on the particular role of data, which as we were all seeing, the Prime Minister was talking about data only this week, is very much of the moment. And we will talk about what I think has been the holy grail of health policy for a number of years, integrated out of hospital care, an idea that that's not a new idea, that it's one that has been quite a tough nut to crack, and I think that is, I really do think that all of these elements, patients of technology and of a rebalanced health service, are some of the key themes that will deliver a modern, sustainable health service that the government wants. So I think that is a superb agenda. I'm extremely proud, the team has done it, not me, I'm extremely proud of the range of speakers that we've assembled today, from former chairs of the Health Select Committee to the patient user of a personal budget, to innovative health companies, small, medium-sized and large. And I think it's just the kind of group that we need to inform us. So I'm extremely grateful to our speakers today. It's not just the speakers, it's the audience too. As I say, we need everyone's ideas. There's always plenty of time for questions in each session. Please also tweet like mad. Reform Health, the chairs will see all the tweets, so we can feed those into questions, and actually Twitter becomes a very good record of the ideas we generate throughout the day, so please absolutely tweet. In full effect, I would like to thank the Reform team who put this together, Charlotte Hamilton-Wright and Maisie Burrows and the rest of the team. It takes a lot of legwork to put an event like today together, so thank you to those and the other members of the team who are here. Maisie, Ellie Harridge and Daniel Elgamry will chair our panels later on. And I'm also exceptionally grateful to our sponsors today, to InHealth, McKinsey and to Baxter. People will know that each of these organisations do a remarkable amount to help UK healthcare directly, but also to help the policy discussion around that healthcare, and it is a real commitment on their part, and I do believe that healthcare is better as a result. So I'm extremely grateful to them for that and for their sponsorship today. We will hear from all of those sponsors later on. So yes, what can I say? I'm excited. And we will move straight on to our keynote speech and panel. It's my great pleasure to introduce the Director of Personalised Care NHS England, James Sanderson. James, we're absolutely thrilled that you're here. We started, we were talking about some of these ideas a few months ago, and we had the idea together for a major event that would give you the chance to set out your latest thinking, and I was absolutely mad keen to do that. I think you've got a big idea, as I say, the empowered patient, which I personally feel, as I say, I think it's an idea that could have been more strongly developed in recent years, so I think if we can talk about it now, I'm absolutely thrilled. So James will please speak to us, and then Baroness Julia Cumberledge and Lucy Watts, MBE, will make short remarks, and then we will join in a very lively Q&A session. James, please give us a few minutes.
Thank you very much, Andrew, and good morning, everybody. I'm delighted to be here this morning to open the conference and to talk to you about the growing need for personalised care in the NHS. I want to make the case for personalised care this morning. I want to talk about what it is, why it's needed, and most importantly, how I think we can do it. But first, I know it's really early, but I wanted to start with a question for you all, a bit of audience participation. I was on the train yesterday morning, and obviously you can't help on trains listening to conversations that are going on across the table from you. And there was two women across the table who were talking about what they had for dinner the previous evening. And one of them said, "What did you have for tea last night?" And the other one said, "I had 4 large glasses of wine and a biscuit." And I was really tempted to ask what type of biscuit it was, because it was quite an intriguing diet that obviously I'm not advocating. This isn't a public health speech, but I'm sure we can find better things. So just a question for you to start the morning off. If you can raise your hand. So who cooked for themselves last night? Oh, that's most of you actually, that's impressive. Who ate out? Who skipped dinner and just went straight for the alcohol and biscuits? No, there was one at the back. One person at the back. Fantastic. I'll return to this later. I'll return to biscuits and wine later. But just to start off, talking about the NHS, as you all know, I'm sure, the NHS celebrates its 70th birthday on the 5th of July this year, and huge amounts of things to celebrate in terms of the NHS and its achievements over the years. And to celebrate the many people across the country, the thousands of healthcare workers that provide frontline service to people every day of the week. The NHS has achieved some fantastic things since 1948. In 1948, a man of my age, 19 and a half years, old, would have had life expectancy of 65 years of age. Half of all men died before they reached retirement age, which of course now everyone will die before they reach retirement age, of course, as retirement age keeps creeping up and up and up. But now we experience life expectancy of 79.02 years. I think that's so precise, the 0.02. I've started thinking about what I'm going to do with that 0.02 if I make it to 79 years. So fantastic advancements, and maybe for a number of reasons. I've mentioned public health and drinking, but smoking cessation has been a huge factor in increasing life expectancy, as have practical things like seatbelts in cars. And also, we die less during industrial accidents than we used to do, which is not a political comment about how much we manufacture as a country. But there's been lots of advancements over that 70 years. But it's also been down to the advancements in the NHS, the excellent care and support, the advancements in technology, the advancements in medicine over that years. However, despite the fact that we're living longer lives, we're not necessarily living healthier lives. And there's a number of challenges because of demographic changes that the NHS is now facing. For example, 7 in every £10 of NHS money is spent supporting people with long-term conditions. 7 in every 10 hospital beds are occupied by somebody that has a long-term condition. And during the winter period, when we all saw pressures that colleagues in accident and emergency departments were facing, 41% of people that were turning up to A&E didn't necessarily need to be there. So how can we start to address these challenges? Do we need a new way of focusing on the things that are precious to people, the NHS, the way in which we manage our own health and well-being? Do we need a new opportunity to think about those things? And that's what I'm going to set out. Now, I was doing some research in terms of what may have happened today that was of any historical note. And actually the answer was almost nothing. I tried to find a nice story that I could say, on this day, this happened. But I did find one piece of information which then, after more and more research, which I think is probably a lesson, if you find something that proves your point, stop there, because the more and more research I did, the less and less likely the facts that I found out became. But on this day, in 1785, Benjamin Franklin is noted as writing a letter that actually gave the first description of bifocal glasses. And there's some dispute as to whether or not he invented them earlier or whether it was attributed to lots of other people. But in 1785, as I say, Benjamin Franklin wrote about bifocal glasses. And he talked about the fact that sometimes the lens that you look through may not be the best lens for the job in hand. So that's what I want to explore a little bit. You know, we spend a lot of time in health looking at ways to transform health, having discussions about certain issues and certain challenges in health, but do we always look through the right lens? Is there another way of looking at it? And I think this is where personalised care comes in. How can we start to shift the NHS to look more through the lens that focuses on an individual? How can we put individuals at the centre of their healthcare and start unlocking the opportunities that personalised care can bring? So personalised care is a growing priority for the NHS and for government. In the next steps of the 5-year forward view, we talked about that we would deploy rigorous and validated population health management capabilities that improve prevention, enhance patient activation and supported self-management. We did use some really big words in that sentence. We also talked about the expansion of personal health budgets, a way of maximising choice and control for people by transferring power into their hands. And more recently, the Secretary of State has talked about wanting to achieve full integration of health and social care centred around the person and giving the highest possible control to those who are receiving support. So some big goals that we've set out for the NHS, and there's a number of reasons for that. In terms of creating an enabling philosophy in the NHS, how can we start to change the relationship where citizens are partners in their own care? How can we start to create a more equal relationship between clinician and patient? This is not about throwing away medical knowledge and expertise. We need that. We need wise counsel in times of need to support us by making the right decisions for us. But actually, you know, clinicians will always be experts in the condition or disease, but they're not necessarily experts in the individual. If you think about it, we've all lived with ourselves since before we were born. Just think about it for a little bit. I know that we probably weren't that much conscious of our own health and well-being before we were born, but anyway. So how can we do this? And what we've done more recently at NHS England is we've created what we're calling is our comprehensive model for personalised care. I'm really delighted to introduce you to what is version 2 of our triangle. Every good model starts with a triangle, I think. There's lots of exciting triangles in life. But I think this one and Toblerone are probably two of the most exciting. So what we've tried to do with this is we've tried to identify some of the interventions on the left-hand side that can support a shift to personalised care. Things like personal health budgets, things like social prescribing, linking people to activities and support in the community. Things like patient activation, how we can build skills and confidence to self-manage, how we can use health coaching as a way of unlocking knowledge in an individual so they can better manage long-term conditions. how we can deploy universal approaches to patient choice, using choice as an enabler, not just for the individual to get them the services that they need and want, but also to look at managing demand in the system and look at trying to divert people to better forms of assistance for their needs, rather than 41% of people turning up in A&E that perhaps don't necessarily need to be there. So how can we deploy those interventions? And how can we attribute those interventions to the whole population? How do those things fit together? And also what the impacts could potentially be. So this universal model tries to bring everything together to coordinate care much more effectively through those series of interventions. But actually, what the NHS also needs, because the NHS is a really complex organisation and has many aspects to it, it also needs an operating model. And I'm going to put the next one up, and you're probably grown by all the information that's on there. Not necessarily the best slide. But I have to say, before you start criticising me for being a bureaucrat from the NHS that's put a really complicated model that's not accessible at all up there, I can say that this has been co-produced with the NHS, with the Local Government Association and ADAS, but most importantly with people with lived experience of health and care. And this came out of a programme that we ran for a couple of years, and we're still continuing to expand now, which is called Integrated Personalised Commissioning. So this model, whilst it appears incredibly complex, is actually fairly straightforward. And the key shifts across the bottom are the things really that you need to concentrate on. Firstly, we need to make sure the system is taking a proactive approach to managing and supporting people with long-term conditions. Secondly, we need to engage with people using person-centred care and support planning and shared decision-making to find out what matters to them. We need to move the system from a position of what's wrong with you to what matters to you. And having that conversation, having that different approach will start to generate ideas around how that person could best be supported. We also need to start unlocking what's available in the community. I was reading the other day that I think the estimate is that community-based interventions and informal care is equivalent to the same level of input to the NHS. It's like a second NHS in terms of cost and size. But are we making the best use of it? Are we making the best use of those things that already exist in the community that can help support people's health and well-being? We also then need to give people choice and control. We need to use enabling interventions that unlock the assets that people bring to their own care, that use the fact that people, as I say, are experts in their own health and well-being, and how we can connect that with what the system is providing. And finally, we need to look at shifting the commissioning system. We need to look at making sure that this approach to personalised care actually fits in to the mechanisms and the approaches that we have in health. We've identified a number of priorities over the next year. In looking at how we can really accelerate progress in personalised care, we feel that these interventions are the key ones for the system to adopt. And we're working with a number of areas across the country. We're working actually with 22 areas that represent almost a third of the country, with some really significant STPs and integrated care systems within that block. And those areas will be introducing this comprehensive model for personalised care using this model. So the things that I've highlighted there, integrated personal commissioning, as I've mentioned, is the model of care. That's the thing that will drive this. That's the approaches using these 5 key shifts that enable clinicians to take a different approach, to use this model to work with patients through the system. Then we need to move to person-centred care and support planning as the gateway to approaching their health and care in a different way. We also need to use health coaching and patient activation measures to help build skills and confidence to self-manage, linking people to what's available in the community through social prescribing, using personal health budgets for people with more significant needs. And finally, we also need to make sure that all of the approaches that we have through traditional models of care, the biomedical interventions that we need, also have choice and control built into them. So are we giving patients choice of those methodologies? So how can we bring all of this together? I want to now just focus on a few things, just to give you a bit of a taster of some of the elements that are in that model. So firstly, personal health budgets. So personal health budgets were trialled in 2009, between 2009 and 2012. And then in 2014, government legislated to introduce a legal right to have a personal health budget for those individuals receiving continuing healthcare funding. We now have 28,040 people receiving a personal health budget. That's the number as of 31st of March of this year. And that's grown considerably over the last couple of years, 266% rise in the number of people receiving a personal health budget. And the areas up there show how we're diversifying the model to support an increasing number of groups. Government, a couple of months ago, launched a consultation on extending the legal right to have a personal health budget. That, if introduced, would take the number of people receiving a personal health budget up to 350,000 people that would benefit from the legal right. And those areas that we're consulting on at the moment are supporting people with a learning disability, supporting those with mental health needs, looking at supporting people receiving adult social care funding, where over 400,000 people already receive a personal budget for their adult social care funding, looking to support wheelchair users to get better equipment through more choice and control through a personal wheelchair budget, and finally supporting people who are who have served in the military and requiring care and support after their discharge. So a number of interventions, a diversifying model, and an ambition to get to 40,000 people receiving a personal health budget this year. Personal health budgets aren't without their controversy though. We occasionally get lots of myths reported about what they are and what they aren't. Occasionally people will say, well, personal health budgets are just the NHS giving people feel-good treats like iPads. And you know, if you look at that through one lens and you focus on should the NHS be spending money on an iPad, you may make the conclusion, well, no, it shouldn't. The NHS should be about healthcare. But you look at it through another lens and you focus on really what that iPad is doing, and you consider that that iPad is supporting someone with motor neurons, is supporting them to control their lights and their heating, and answer the door to their home, perhaps close and open curtains in their home, use it as a communication tool, be able to shop, be able to speak to their friends online. And you realise that that iPad could potentially save the NHS and the care system quite a considerable amount of money, because it could replace the need to have human intervention 24 hours a day for that individual. There's also reporting around the NHS spending money on pets, and you'll hear Lucy speak about the support that she has from Molly shortly. It's great to have Lucy with us today. But you know, the misreporting focused through one lens on should the NHS be spending money on animals, but then you consider the opportunity that comes from people being supported by assistance dogs. A case of Jackie Kennedy, who's supported the programme as one of our peer leaders. She estimates that Kingston, her support dog, who can recognise when Jackie, who was injured as a Metropolitan Police officer, attacked on duty, became disabled as a consequence of the attack. When Kingston can identify when she's about to have a seizure, and can also support her by picking things up off the floor, helping her get dressed and undressed. And Kingston is estimated to have saved the NHS over £130,000, prevented Jackie from going into the hospital 9 times in the last year alone. So if we look at personal health budgets through a broad lens, sometimes it is marked with controversy. But if we look at it through a lens focusing on the individual and the impact that that has, both for the individual and the health service, we can see some of the opportunities that are there. Some of the evidence that's emerging from personal health budgets. I mentioned continuing healthcare earlier. In continuing healthcare, we're experiencing an average of 17% cost saving on the cost of delivering continuing healthcare if the individual has a personal health budget rather than traditional forms of services provided directly to them. The reason for this is threefold. Firstly, people become activated. People stop being passive recipients of care done to and become active participants in their care. And that enables them to take greater control of the money. That enables them to think more carefully about how they're going to manage those budgets. And as human beings, we tend to manage money relatively well. Occasionally we don't, but we tend to manage it relatively well. Secondly, people are able to buy care directly that's sometimes cheaper than block contract agency care that's sometimes commissioned. So people are able to employ their own personal assistant directly rather than employing expensive care through a care agency. And thirdly, as I mentioned, people are able to buy different things that perhaps replace the need for human intervention. So digital technology, like iPads, but also apps and wearables. I'm delighted that Juliet Barrow and Will Smart will be speaking later about the digital revolution that's happening in the NHS to support people. But also assistance dogs and other forms of support like that. So those three things combine to create a really great opportunity for both individuals and the system. We've just undertaken a recent survey, and personal health budget holders, 97% of them said that they were positive about the impact that their personal health budget had had, and 75% of people said that their personal health budget had improved their health and well-being. So if we could do something by focusing through a different lens that not only transfers power to individuals, gives them choice and control, improves their health and well-being outcomes, but also at the same time, as some of these examples show, reduces demand on the system and also reduces cost to the system. Surely that's a good way of developing a transformed health service. Just to look at one other area, patient activation measurement. Patient activation measurement is a tool developed by Insignia Health. And what this does is it gives everybody a 4-point score on how confident they are, what skills and knowledge they have to manage their own condition. And this is a really exciting way of tackling health inequality, because we tend to find those with the lowest confidence, those with the lowest skills, are suffering from the greatest health inequality in our society. And by working with them, by using health coaching, by using opportunities to increase their health literacy, we can start to transform not just their lives, but also the health inequality that we face as a society. Some of the emerging evidence from patient activation measurement represents that when people are moved from a level 1 activation to level 4 activation, they're able to reduce their requirement on the NHS. So there's a 19% reduction in the number of GP visits. There's a 38% reduction in the number of A&E attendances, which is obviously, again, clearly great for them and for the system. And finally, social prescribing, which I mentioned earlier. Social prescribing is an opportunity to link people to services in the community. The most important part of social prescribing is that GPs and other healthcare professionals are able to refer somebody to a link worker. That link worker is somebody who has expertise in what is available in the community. So looking at trying to meet people's psychosocial needs alongside the biomedical interventions that are already supporting them through the health service. So how can we get more people engaged in walking groups, in perhaps having cookery lessons to help us with better choice than 4 glasses of wine and a cookie? How can we support people who are lonely to connect with peers, connect with people with similar lived experience, and how can we talk to them around the care and support that they could perhaps already be getting from the communities in which they live. Now, this isn't about signposting, or as I say, deterministic pointing. This isn't just about throwing people to the community because you can't be bothered to see them. This is about working with people through that person-centred approach that I've mentioned and finding out what matters to them. And we're finding that GPs all around the country are starting to really, really embrace this. The RCGP recently said that it was one of their key priorities for the reform of primary care. And GPs are starting to implement social prescribing in their practices. We estimate that around about 50% of the country is already engaged in some form of social prescribing. So what I've talked about today is how we can start to bring these things together, how we can start to scale up these interventions, how we can start to transform the way in which the NHS focuses around the needs of the individual. And these aren't programmes that are niche pilots for the NHS. These are things that you've seen in setting out priorities for government and in the NHS 5-year forward view, are things that we're wanting to scale right across the NHS. This is where we've got to at the moment. This is the sort of scale that we're reaching. 173,000 people have experienced the integrated personal conditioning care programme. We've now got over 75,000 people that have had a proper person-centred care and support planning conversation to help them manage their needs. I've already mentioned personal health budgets, patient activation assessments, 57,000 people now have gone through those. But this isn't enough. we really need to continue to expand these opportunities across the system. We need to continue to do that because there's a growing imperative, because of the challenges that the NHS faces, but also because of the changes to ourselves as society. I asked you a number of really simple questions at the beginning about what you had for dinner last night and whether you cooked for yourself. Choices that we make every day are really important to us as human beings. Choice is a fundamental part of what being human means. If I ask you all another question, do you enjoy being excluded from decisions and information that affects the most sensitive and personal parts of your life? Nobody's putting their hand up. So how can we start to shift the system towards a more person-centred approach? How can we change that lens to focus on the individual? Thank you.
James, thank you very, very much indeed. There has been some examples of personal control already at this conference. People are getting their own chairs at the back to sit down rather than coming to seats at the front. So please, anybody who wants to come and sit at the front, please do. You've exercising personal control. Thank you. Can I please ask Miss Julia Cumbridge to give your 5 minutes, please?
Well, thank you very much indeed, Reform, for inviting me here today. I met James yesterday, not for the first time. We've worked together quite a lot over the past few years. And I said to him, I'm coming here today to listen to you. And the more I listen to James, the more I think this is a real game changer. This is something that makes such a difference to the NHS. I'm going to concentrate on, perhaps you may think a minority sport, which is maternity services. But I have spent the last 3.5 years doing maternity. And it started with this report, Better Births. And once we produced the report, and someone in NHS England has got a sense of humour, because we were given 9 months in which to do it. And after the 9 months, we produced a report. Simon Stevens then had a look at it and tweaked it a little bit, but not much. And then we've been implementing it. And the more I see of reviews, of investigations, the more I think all these wonderful words that are put up into books, reports, whatever, onto shelves, and nothing happens. And that makes me so cross. So we've been spending a lot of time on implementation. Of course, every one of us, I suspect, in this room has been touched by a midwife. They are really important people, as are obstetricians, anaesthetists, all the whole clinicians that are involved in maternity services. When we were doing our report, the first thing we did was to go around the country and to talk to people. And we had drop-ins. So 8 in the morning till 8 at night, never on an NHS premises, but where women wanted to come and where a lot of midwives turned up as well, a lot of GPs, obstetricians and others. Because we wanted to hear from them exactly what they wanted from the service. And to me, it was captivated by what one woman wrote on the board. And because we have this great white wall where people were writing stuff. She said, listen to me. Don't overwhelm me with your paperwork. Treat me kindly and with respect. Let me decide what is important to me. Don't patronize me. It's my body, my baby, and my new family that I am creating with my partner. It's our decision. please honour that and wrap your services around us. So to me, that really says a lot about personalisation and a lot about choice. And the words that strike me very strongly: listen to me. Often we hear, we're too busy. I've heard women tell of the stillbirth that she had, and every time she goes with her second pregnancy, she has to go through that whole story again. Because the midwife will say, and how's the little one doing? Nobody's read the notes. Let me decide. No, we are the experts. We decide. Don't patronise me. I went to a place on the South Coast, and I was talking about continuity of care, and I want to say a word about that in a minute. I spoke to the head of the maternity services, who was the obstetrician. And I was talking about how they had done so well with continuity, using the same midwife through antenatal care and postnatal care, but not the birth. So I congratulated him on this, and I said, but women are telling us they want the same person through the birth. My dear, bad thing to start. My dear, he said. Because I had told him we talked to thousands of women. My dear, you have spoken to the wrong women. What a classic. So our decision, honour that. Well, we are the experts. We are the clinicians. We actually have had years of training, and we know best. Wrap your services around us. What a strange idea. We provide. You fit in. So to me, wrapping services around the women, the family, the baby, is giving women choice. We, in our report, were very keen on choice, and we gave 4 places to give birth. And we based it on the NICE guidelines. Home, freestanding maternity units, alongside maternity units, and obstetric units. 2% of women only give birth at home, 10% wanted. Freestanding units, again, 2%, 6% wanted, alongside 9% get it, 49% wanted. Obstetric units, only 25% want to give birth in the obstetric unit, 87% do. Now, of course, I understand sometimes you have to be transferred into an obstetric unit, but what a difference, 25% to 87%. So, continuity of care is about safety. And we have at last persuaded Jeremy Hunt this is a really good thing to be doing, because we know that if you can provide continuity, you then get 24% reduction in premature births. That's huge, 24% reduction. So I think my 5 minutes is up. I just want to finally say that Simon Stevens has been terrific in our maternity services in trying to implement it. And unlike a report I did years ago, Changing Childbirth, now NHS England have put a scaffolding around our report, and we are seeing some magical things happening, not least personal maternity health budgets, a great game changer. Thank you.
Thank you. I should have said that all of our speakers' biographies are in the programme, so I haven't read them out. Lucy Watts, please.
So, I'm 24 years old, and I have a life-limiting condition that causes very complex medical needs. It means I need round-the-clock care from intensive care nurses and overnight carers, as well as the support of Molly, my assistant's dog, who's fantastic. I started off employing staff via social care direct payments after becoming poorly at the age of 14, born with health problems, but they didn't become apparent so severely until I was 14, which meant on social care direct payments, although my mum ran the package for me, I chose my staff and I was in control. As my needs increased, I became a user of NHS continuing healthcare. This was provided in the form of a personal health budget. In this package, I employed staff, PAs for some hours a week. I had 2 days a week at the hospice, and then my mum was paid £14 an hour for 3 hours care a day to do the 24/7 nursing care, as opposed to a cost of £40 per hour for 24-hour nursing. She saved the NHS a lot of money. Paying my mum to provide this care also enabled me to have the care I wanted to have. No one cares for you better than your family, you've got to admit that, and it meant it was my life under my control. However, 3 years ago, only the other day actually, 3 years ago, my mum became poorly, and the package I had was inadequate. So, in a very short space of time, I had a package retaken back by the CHC team, which I'm still on, but I'm going back into a personal health budget, and I can't wait to be back in control of my life again. The other things that would have benefited me were a personal health budget for a wheelchair. 3 years ago, I had to fundraise for this wheelchair that I'm sitting today at £22,500 to get what I needed. I couldn't get anything suitable in the NHS, but a personal health budget for wheelchairs would have made a big difference. Also, Molly obviously provides a lot of support to me. She can't do everything, but she provides a lot of support. And like James mentioned about my friend Jackie Kennedy, who her dog, Kingston, is paid to support her. Molly is not paid under my package, but why shouldn't she be if she's providing care? Palliative care has also been an important part of my life, and as I said, I paid the hospice 2 days a week to look after me. Their support has undoubtedly saved the NHS a lot of money, having clinical backup and support at the end of the phone. It also meant very holistic, supportive care, as the whole ethos of palliative care is, which has enabled me to outlive my prognosis. It's also enabled me to become an advocate for others, for which I received my MBE in 2016 at the age of 22. But through both my experiences and my work and my connections, I've seen the benefit of personalised, person-centred care, but also not just the impact on us as individuals, but on our families and carers. For so many of us, it's been life-changing to have a package of care built around us and our needs, our unique needs and our wishes, rather than the services saying, this is what we're going to provide, and that accept it or don't. The evidence I find many professionals face around the personalisation and person-centred agenda, especially personal health budgets, is that it's an action that you do. It's not. It's a whole different ethos of care that requires a new approach and a culture change. You do have actions as part of personalised care, but you also need to change the whole shift in how you manage things. I think treat personalisation as an action and you will miss the mark completely. It starts with personalised provisioning, both for the individuals, but also for the local community around, and then a person-centred planning process from which a very holistic, tailor-made package of care can be built. Person-centred planning, as James said, is all about what matters to you, not what's the matter with you. It's about what do you want to achieve, what makes your life worth living, and how can we help you to achieve that. It's all about empowering people like me, who have so little control in our lives, to take charge of our lives and of our health, and have a good quality of life. Personalisation requires us to think differently about the way we work. It's to focus on the needs of the individual, but also their desired outcomes. Building packages around the care of the individual not only improves outcomes, but it actually saves money, as I mentioned earlier. Personal health budgets are one way of achieving personalisation. A benefit of personalisation, and I hope I've shown here how important it is. James explained the important aspects of it, including social prescribing and everything like that. But I'm here to show the patient side. And it's really important that people understand it's not just about benefiting the NHS, benefiting us, and putting us in control of our lives. Can you imagine your life as it is now, having someone saying, this is what time you're going to get up, this is what you're going to do today, this is how we're going to provide your care, and then suddenly, after all these years, someone saying, how do you want to be cared for? What do you want to do? How can we help you achieve that? It transforms your life, and it gives you back independence. And for me, I'm very dependent on other people, but being able to control who looks after me and how that care is provided gives me back control over my life. Personalised care can, does, and already is transforming lives, and I hope you see that today. Thank you.
Lucy, thank you very, very much indeed. People have been tweeting saying this is a great place to start a conference on reform of the NHS, and I think that's true. I guess what have we heard? Our speakers have suggested to us that these ideas are a game changer. Is that something we agree with? I'm personally very moved by this. It strikes me as an enormous chord with me about a different approach to providing healthcare. Do we agree with this? Baroness Cumberledge, I thought, sort of gave a sense that this is about sort of cutting through some of the inertia and bureaucracy might not be the right word, but the sort of the way that services get stuck in a particular pattern, and this is a way of cutting through that. And Lucy, dare I say, has reminded us that this is about dignity, and this is which is quite honestly what should be at the heart of providing public services. And along the way, we've noted that because services are being provided better and more accurately, and with greater awareness of the cost of those services, as it happens, the cost of the whole thing comes down as well, which is not the main reason to do it, but it's always very important. So let me please open it up. Let's decide if this is a game changer. I'd like to take 2 or 3 questions together, please, and we'll please do people to say who they are. So we'll go to Nick Bosenkesh at the back, and then we'll come forward to you.
Thank you very much. But I want to introduce a note of really strong realism to it. There is violent opposition to this idea, a very deep opposition within much of the NHS. They say it's a way of wasting money and that it's irresponsible, that it can't meet clinical governance standards, etc., etc. How do we give patients more power to actually get these personal budgets? It's 15 years since they started. In fact, one of the best early trials was in Manchester, which showed that they were highly positive for elderly people.
Thank you. We'll come forward to another hand, please.
I'm from the MS Society. My question is about how we're going to avoid creating massive inequalities and what people can access. So only some people can have this wonderful kind of choice and other people can't. And related to that is social care. Everyone who receives social care should get a personal budget and they should have all those choices. I think we've spoken about. And we know that that's been massively undermined at the moment. There's a great framework in place under the Care Act to deliver that, but it's not happening because of the funding. So again, how are you going to ensure there's not that inequality between what people can get in social care and then when they go on to continue healthcare and other personal budget and health?
Thank you. And all the hands are at the back. So we'll even it out across the room. So I'll keep your hand at armrest and George, bring me. Okay, I'll go back, please.
Good morning. I'm Bhargav. I'm a GP and ex-chief officer for CCG. I absolutely agree that with Baroness Cumberledge, it's a game changer when we shift from pathogenesis, looking at the cause of disease, to salutogenesis, when we start focusing on the cause of wellness. And that's where we flip from giving the patient having a choice architecture for commissioners to having a choice architecture for patients where they choose, as Lucy was saying. And I think, going with Nick, some of these things are really important, and James, you're absolutely right to put it in a framework which makes sense to me as an ex-commissioner, but now looking at it from a wellness side as a GP. But going with what Nick was saying, when we had the shifting the balance of power, we had similar conversations. And we've been talking about social prescribing for a little while. And the shared decision making was part of right care. And a lot of good work was done on it. The challenge for us is, and shared decision making is important because 20 to 30% of people who have knee operations or prostate operations or cataract operations are harmed by that operation because they weren't given the right, the shared decision making. So there is evidence that it does. The challenge here is, and the question is, how are you going to implement the evidence that we've already created into a commissioning framework that mandates providers to respect not only the patients, but the evidence that has already been created?
Thank you. So I mean, I think there's quite a lot there for you, James, I think. So, yeah, here we are. You want to shake up the NHS, quite right too, but how exactly are we going to do it? As people have been saying, there have been these ideas that have been tried in recent years, but perhaps haven't had the cut through that you're hoping for. What's different this time? And then we might come to a word on the money and contrast to social care. And then I thought I might just ask Julia and Lucy. Some of the questions there are about the culture and the culture of medical staff and whether medical staff in some cases might find it hard to adjust to this new way of thinking. I just wondered how that fitted with your experience so far. Should we start with James?
Thank you, and thank you for all of those really simple and straightforward questions as well. That's really helpful to start us off. Huge challenges. I recognise everything that has been said in terms of the challenge of how you bring the clinical profession along with you, how you meet the challenges of demand in the system, the financial aspects as well, and how you effectively commission this and get it hardwired into the system. A few things then in reflection for all of those challenges. First and foremost, this approach is not right for every situation. Hopefully I won't be, but when I'm walking to my next meeting after this event, if I'm knocked over by a car and I'm semi-conscious on the road, I don't necessarily want the paramedic leaning over me saying, what matters to you? What's a good day look like? There are times in our life when actually we need the NHS to do what the NHS does very well, to pick us up, to help us out and support us. So in terms of engaging with the clinical profession, this is a challenge to what they are currently doing, because what they're currently doing is fantastic and needs to continue. This is about how we can start to work differently in partnership more effectively with patients. There has been opposition in the past, but I think that's changing quite significantly. We've seen a huge shift over the last 2 years in the way in which clinicians are engaging with this programme of work. In Stockton-on-Tees, for example, where one of our first sites to implement the integrated personal commissioning model, we had 5 GPs that worked around a number of practices in the area, and a number of those were really opposed to starting to change the way in which their practices functioned. But by the end of it, they were all saying, this is why I became a doctor in the first place. This is how I want to support my patients, how I've always wanted to support my patients, but I've not been able to do it because of the time constraints. And they've seen how these interventions start to free up time. And there was an average of 12% saving in terms of the general practice time that was experienced by those GPs in Stockton. I think the other point around how we do this is the issue of fragmentation in the system, because all of those interventions I spoke about have been operated, as you were saying, at certain points in time in different parts of the country. But actually we have lots of competitiveness. We have the people in Stockton-on-Tees saying, this really works for Stockton, and then people in Portsmouth saying, well, yeah, but that wouldn't work for people in Portsmouth. And people in Portsmouth saying, but this is what works for Portsmouth, and people in Kent saying, well, no, that wouldn't work for people in Kent. And areas are very different, and people are, of course, very different. This is all about personalisation. But actually what we're trying to do with this model is create a number of standard off-the-shelf products that can start to cut through that not invented here syndrome, that can start to be simple things that the system can adopt. And the way in which we hope to really transform the system is start hardwiring this model into the way in which the NHS is moving forward and transforming as well. So it will be a requirement of integrated care systems and STPs to be implementing the IPC model. it is a requirement of CCGs now to increase the number of people on personal health budgets, and there are targets in place. We're increasing the legal rights. So we're starting to look at putting this into the very heart of the NHS, but at the same time, as hardwiring those things in, we're also hopefully changing hearts and minds by the impact this has on the profession, and also the impact this has on individuals, which is obviously the most important aspect here.
Thank you. And just a supplementary for me. So just in terms of numbers, so 30,000 now, and suddenly 300,000, nearly 400,000 before 2 months. I can't remember the exact year. So that's quite a significant change. I mean, so I haven't got a sense of the population. I mean, does there need to be then another growth in the number before it feels like this is kind of business as usual across the NHS, or do you achieve that with 300 or 400,000?
I think that's really interesting. So in terms of the rise in the number of PHBs, mentioning it's been available in social care for quite a number of years, it actually took 10 years in adult social care from 97 with the Direct Payments Act coming in. It took 10 years to get to the first 10,000 people receiving personal budget in adult social care. There's now 400,000 people. In less than 10 years, we've gone from 0 to 28,000 in health, which is quite considerable acceleration. But we do need some volume before that becomes mainstream, as you say, Andrew. I think the tipping point for me is where commissioners start embracing this and really changing their practice. And we're starting to see that with wheelchair services at the moment, where when we first introduced the concept of personal wheelchair services, commissioners were saying, we don't know how this can work with different contracts. And we've now got a number of areas of the country that are starting to renegotiate those contracts and actually make those contracts about personalised care and support.
Thank you. And can I ask Julia and Lucy how as I say, do you sort of see this as, you experience this as a sort of challenge to existing ways of sort of culture?
Well, no, actually, Lucy, you talked about culture, didn't you? Changing culture. One of the things that I do is to chair something called the Stakeholder Council. And the Stakeholder Council are all sorts of people who are involved in maternity services. And one of the things we've been working on is how do you change the culture? And we have put 4 questions down to the NHS, and we feel it has to come from the bottom up, not the top down. And so we're asking right throughout the units, the local maternity systems to start with, but certainly it's got to get down to the units. And the questions are things like, why is maternity services different in terms of its culture? And I have to say it is. I mustn't give the answers because we're asking people just to answer the questions. The second thing is about how would you like the culture to change? And the third one is, what would you see if it does change? So we're really trying very hard to work on that, and I'm doing it with Cyril Chanter, who's my vice chair. I just want to say that in maternity we are still in the nursery slips. James has said how we've accelerated in personal budgets throughout the 10 years. When I chaired social services, we were just beginning to do this. But in maternity services, Jeremy Hunt has now set targets. Jeremy Hunt is very fond of targets. And I'm actually very pleased about these targets. And we've got to have 130,000 women by this time next year on personal maternity health budgets, and 3,000 women by 2021. So he's really very, very keen. Already we've got 19,000 on personal health maternity budgets. So we are getting there, but with James and all your wonderful team, we're going to actually accelerate this. But the problem is that certainly with midwives, they see this as privatisation. They don't see this as part of the National Health Service. So we've got a huge job to do to change minds and hearts. And part of that is ensuring that we get continuity of the person looking after the woman throughout 3 stages. So prenatal care, birth and postnatal care, because that is what women want. if we can get the personal health budgets really, really solid foundations in the 7 pioneers we've got at the moment, so we have to start with certain groups, so we've chosen 7 pioneers to do this. And if we can really get that to happen, then we are sure it will spread, because this is what women want, and this is what the service is going to have to provide.
Thank you.
I mean, as we said, it's a big culture change, and I think there's and I find this in my work as well, just as an advocate, there's this worry about this balance of power changing, and we're not going to put ourselves above the professionals, but it's an equal footing. And actually, if you can work in partnership together, surely that's got to be better. And I think, being on a level with my medical team and people involved in my care, we have open and honest discussion, but also I'm responsible for myself. We as patients, we all do it. Put our trust on, the doctor's going to do everything for me. I don't have to take responsibility for my care because they're going to do everything. It's like, no, actually, if you don't take responsibility, it doesn't matter how many doctors you see, how many treatments they prescribe, if you're not going to follow that, take responsibility. So I think, we need to kind of get people to understand that we're not shifting the power balance, we're just equalising it a little bit. And you will always be the professional, we'll always be the patient, but it's more on the equal footing. And also I think it's changing us from passive recipients into active, engaged, partners in our care, and I think that's really important.
So do I. Do we have any further questions? So just quick points, please. So you put your hand right up there so we can see Neil Griffiths, please, and we'll come to the back row, and that will be our last points, and we will take further points.
Can I just say, first, thanks for 3 very inspiring talks, and I do concur with the view that James has got on his hands, the makings of a game changer. But not just for the NHS, and I just wanted to chase down the local government point a little bit more, given that so much of what James is trying to achieve reaches into the ambit of local government, not just in social care, but also in public health, and given the sense that people are feeling sometimes expressed by local government that they feel a bit like patients themselves being told what they should do and how they should go about their business and what's best for them. How do you get local government to be at the heart of this and fully part of this?
Thank you. And we've got a hand right at the back, please. Thank you, sir.
I hope this is not a visual curry moment, but
just not 10 minutes, please.
I'd just like to make 1 or 2 points. As a clinician, as an economist, having worked across 4 continents, I think we're rehashing the same old arguments. And the thing is that unless the model is changed, and when I say the model is changed, the variables that are put into the model is changed, and there is intersectionality in putting in those variables. All this good work you're saying will not work. And one last point I'd like to make is that patient-centered care is very, very important at the primary level to stop things going up to the secondary and tertiary level. And because it's so important at the primary level, we really need intersectionality at that level to determine the right variables so that we can have a solid foundation on which the community can build and make these changes. Thank you.
Thank you. Well, do you want to just say a little bit more, as a layman as I am, when you say intersectionality, what exactly are you getting at there? Just briefly.
My parents worked for the NHS and I worked for the NHS for a while. And one thing I noticed is that when I used the term marginalized group, and I use that in inverted commas, don't tend to have the personalized care that they deserve. They tend to have a one-size model fits all. And also the cultural aspect. There needs to be a cultural understanding among disabilities, among ethnic groups, among age. There needs to be a cultural sensitivity and understanding of what matters to them. Otherwise, we're putting the same variables into the model and hoping for change, which I'm not sure will work. Thank you.
Thank you. No, I appreciate that. So I understand it. It's about making sure these opportunities aren't limited just to some perhaps more advantaged groups. Okay. Well, these, just for time, I might just take these points to. Let's take up the whole panel if everyone wants to come in. So local government, how do we ensure these opportunities are available for all patients? And then last innocent question for me. So end of the year, Prime Minister stands up and says we're going to have a long-term plan for health, an extra X billion pounds a year, done in, in all the different ways we need to do to ensure that money is well spent. What would be your hope of how some of that whole announcement plays out for personalised care? So should we start with Lucy this time, if you want to come in? And then...
I mean, my kind of hope is that actually everyone is offered personalised care and given that personalised care, but, for example, personal health budget is not right for everyone. It might be the right time. It might be an acute phase of illness and actually needs to wait for it. And I think it's having that adaptability. I really would like to see the NHS be able to adapt and change for the individual, rather than be so rigid across the board, and actually, within your parameters, actually target the different groups differently on their level, and be able to adapt to change. I think that's one of the biggest things for me. The NHS is not very adaptable.
Thank you so much, Lucy. Franz.
Just to say that I'm going to leave it to James.
Thank you very much. I was just thinking about what I was going to say while you were speaking. Just in terms of the local government challenge, then, Neil, your point, which I completely agree with, we need to bring local government along with us. And actually, our approach to this model is that we're co-producing it with the LGA and ADAS, I co-chair a board with Sarah Pickett from the LGA that is building this both in health and social care. And in terms of the sites that we're working with to land this model, they are working absolutely in true partnership across both health, social care, but also with the voluntary and community sector as well to land this, because it can't just be the NHS doing this on its own. And actually, the way in which we're achieving that is by demonstrating the impact of this on people and on the system, as I said before. Lucy mentioned the real problems with wheelchairs and accessing the right sort of wheelchair for your needs. Some of the work that we've done through our integrated approach, working with social care, has identified that some people get a wheelchair provided by health and social care and education sometimes separately. And actually having a conversation about how we can join those services up is achieving some really, really great things. We've got one case where there's been a £14,000 saving, but the individual had the wheelchair that he needed for his life, and despite the fact being refused by all the systems, because it was above their spending limits on an individual basis. So you bring these budgets together, and also bringing together things like disability facilities grant and other benefits from the system, we can really start to change the way the system works. So I think it's just about a different conversation at a local level between all those partners involved. Sarah's comment, I think Sarah, completely agree. This has got to be a fundamental change to the way in which we approach it, because otherwise, if we don't start implementing personalised care in every aspect, it won't have the impact that we think it can truly have in the system.
And hopes for the 10-year long-term plan, not so much hopes, but how should that opportunity be used to help this, what you're trying to do?
My view, obviously the long-term plan is going to be a complex piece of architecture for the future of the NHS, and it's going to set out, I'm sure, some bold challenges and opportunities. I think the role of personalised care is to look at how that can underpin all of those challenges, whether those challenges are for cancer or mental health, or primary care or A&E. Personalised care has got to form a part of that journey and of that challenge. And I think later on you'll hear about how digital tech is also part of that underpinning challenge that we need to meet.
Thank you. I'm slightly overrun. I'm sorry, so I apologise for that. But frankly, I got quite carried away and it's so enthusiastic about this panel that I couldn't help myself. We've talked about the idea of the game changer. I don't need to repeat all that. The sense in the room for the questions was not disagreeing with that, but dare I say a sort of hint of frustration that we may have touched on some of these things before. How can we make it different this time? What our panel have said to us is that let's be honest about this. This is a kind of care we should be trying to deliver anyway. So we should sort of remind ourselves of the principle here. But also we have increasing amounts of practice which demonstrates that this change in culture, which sometimes needs to happen with clinicians, can be done. and that there are savings in terms of financial savings, as you've said, which is important at this time. So I'm perfectly happy to end this panel on an optimistic note. We're going to take a few minutes to move from our first panel today to our second one, which Maisie will share. So please just give us a few minutes to do that, and perhaps we can just thank our first panel.